Welcome to Checking In, a Scottish Rite for Children podcast, where we'll share up-to-date expertise on children's muscles, joints, and bones. Scottish Rite for Children is one of the nation's leading pediatric orthopedic centers. Since 1921, we have been committed to caring for the whole child, mind, body, and spirit. Today, our world-renowned medical staff treats a wide range of pediatric orthopedic conditions, including sports injuries and fractures. Our specialists also excel in the treatment of related arthritic and neurological conditions, as well as learning disorders like dyslexia. Through outstanding care and compassion, Scottish Rite has become a place of hope. We are dedicated to beating the odds in the face of adversity because it's our mission to give children back their childhood. And now, your host, Jennifer Bowden.
Hi, everyone. I am Jennifer Bowden. I am one of the nurse clinical managers here for the ambulatory care department at Scottish Rite for Children. Welcome to Checking In. I'll be your host for this podcast, where we will have an open discussion with our various experts about the different conditions we treat. We want this to be a resource for you and your family, whether you are a current patient, possibly need our services in the future, or just looking for information. Today, we are talking all about surgery for Adolescent Idiopathic Scoliosis, or AIS. When surgery is needed, what's involved, what to expect before and after surgery, and lots more. So let's get started. Today, we are checking in with one of our pediatric orthopedic surgeons, Dr. Amy McIntosh. She is definitely one of our spine experts. Welcome, Dr. McIntosh. Thanks for joining us today.
Thanks for having me. You know how much I love talking about scoliosis.
Yes, it's our favorite. So if you could just kind of start us off with kind of what is scoliosis, more specifically, kind of what is adolescent idiopathic scoliosis? What is AIS?
Sure. So AIS, or adolescent idiopathic scoliosis, really just means that you have scoliosis, you presented after the age of 10 years old, and you have no underlying medical conditions, like no neuromuscular conditions, no syndromic conditions. Basically, in very, very generic terms, it just is a medical term that means we don't know why you have scoliosis. But it's also the most common form of scoliosis, and it is by far the most common type of scoliosis that I treat surgically here at Scottish Rite.
Okay, so you would say, like, somebody with AIS, you could say they were otherwise healthy. Everything else is okay.
Yes, they are by far the healthiest patients. They tend to be healthy middle school or high school girls, because it happens in girls 7 times more than boys. And oftentimes there is a family history, because we know there is some genetic predisposition that we work on every day here at the hospital in one of our genetic research labs. So oftentimes it runs on the maternal side of the family. So moms, aunts, or grandmothers may have had a history of scoliosis that was either treated with a brace or surgery, or sometimes just followed with radiographs. It is also the type of scoliosis that we screen for in schools. So in usually middle school, that's when the school nurse has you bend forward and checks your back. Mm-hmm. That is the type of scoliosis that we are screening for in the school screening programs. So yes, you're an otherwise healthy person who really has no symptoms, but either your pediatrician or your school nurse, or sometimes a family member, notices that you have some asymmetry in your back, and then you come in to get an x-ray and oftentimes see a doctor like me.
Gotcha. Okay. Well, good. So I know for sure one of the treatments for AIS would be surgery, but what other treatment options, do we offer, for adolescent idiopathic kiddos?
Yeah, I think that's one of the greatest things about Scottish Rite. We have so many treatment options. So like I stated, one of the treatment options seems weird, but it just is what we call clinical observation, which means your curve is not big enough to treat with a brace or surgery, but we want to follow it closely. So then oftentimes all I do is schedule another visit for you in usually a 6-month period of time. It allows the patient who has scoliosis to grow and for me to see if it's actually going to progress and ever require treatment. So we call that clinical observation. We have a really cool treatment option at Scottish Rite that is not offered very many other places. It's called Schroth. And I think that's a really funny name to say, but Schroth is a type of physical therapy that was created in Germany. And it's a specific type of physical therapy that the motions or the exercises that you do are specifically created for your type of curve by the physical therapist. And every motion is made for your body's muscles and your body's movement to correct your scoliosis through sort of physical training. And we have, I think now 4 full-time Schroth therapists, which is more than anywhere in the state of Texas. And we also have a lot of clinical research going on in that arena, figuring out like which curves are best treated with that type of physical therapy and, you know, sort of what patients it helps the most. So that's called Schroth physical therapy. And we offer that at both our North Campus in Frisco and at our main campus in Dallas. And then a third type of treatment option is a brace. And then there's different types of braces. So we have braces that you just wear at nighttime. And then we also have a brace that you wear both during the day and the night. The coolest thing about our bracing program here is that our orthotists, the people who make the braces, they work at our hospital and they make all the braces in-house. And so we have a really amazing working relationship with all of our orthotists. And all of the braces also have a sensor in them. So we can print off a report card when you come to see us, which tells us how you're doing with your brace wear. But also we have a new type of sensor that works through Bluetooth technology, and it can connect to an application on your phone, and it gives you hourly or daily feedback on how well you're wearing your brace. So that I think is really exciting, and it helps us understand what makes bracing patients successful. And we're having a lot of innovation in just the types of braces we're prescribing and how they're made, just to get the optimization out of a brace. Because I always tell my patients, if you're going to wear a brace, it might as well work really well for you. So we're doing a lot of research there. And then lastly, the final option is always surgery, but that is sort of an option that we try to leave for last resort, meaning I'm a surgeon, I enjoy doing spine surgery, but that's not my goal for you. My goal is to help you try to avoid surgery. And so those are basically the treatment options we have right now at the hospital for scoliosis.
See, yeah, so we've got a kind of a wide variety of options for, a wide variety of patients. But, if you are going to recommend or, offer surgery, what's going to set that surgical patient apart? What would drive you to offer surgery or suggest it to one of our AIS kiddos?
Yeah, I think that's everybody's biggest question when they come to see me, right? Am I going to need surgery?
Right. So
there's some pretty specific guidelines. First of all, you have to have a curve magnitude greater than 50 degrees. And those are pretty big curves. Number 2, you still have to have significant growth remaining, meaning you have not reached skeletal maturity, your growth plates are still open, and you still have, significant growth potential. And what that tells me is that your curve that is already 50 degrees, it is very likely to continue to progress. So those are the patients that meet surgical indications or are our surgical patients. So 50-degree curves or greater that have significant growth remaining are our biggest indication. Now, you can have a 50-degree curve or greater and be done growing, but then the decision for surgery is a lot more, we'll say, relaxed, because there's no significant concern that your curve is going to rapidly progress because you're done growing. So if you finish growing and your curve is, let's say, 55 degrees, the likelihood that that curve is going to substantially progress is very low, meaning the curve will likely only progress 1 or 2 degrees a year. So I always say you're in the driver's seat if you have a surgical magnitude curve, but you're done growing. The choice is kind of more up to you when you can choose to have surgery. And a lot of kids get through high school and then they play sports and then they say, oh, I'm done with that now. Now I would like to have surgery. But if you're young with a lot of growth remaining, then the options are we almost have to schedule it a little more quickly. Does that make sense?
Right. Yes, that does make sense. Can you kind of tell us what you mean when you talk about skeletal maturity?
Yeah, that's a really good question. So there's a bunch of ways that we can try to figure out how much growth a child has left. So that's another thing people ask me all the time. How much taller am I going to get? So we can look at the x-ray. And when we look at the x-ray, there's a growth plate in and around the hip bones that we can judge to help determine how much growth is left. And then oftentimes I send my patient for a film of their hand because the hand has so many bones in it and there's so many growth plates for me to look at, but there's sort of a staging classification of kind of growth remaining called the Sanders stage. And it helps me figure out how much growth you have left. And then there's other things I ask, like how tall is mom? How tall is dad? And then it's kind of interesting, but most girls, and because girls are the predominant patients that need surgical treatment for scoliosis, grow for 2 years after they've had their first period. But that's the kind of the least accurate piece of information. But we always ask everybody, when did you get your first period? And, how long have you been having it for? So it's kind of like taking a lot of pieces of information and then putting it together to decide how much growth is remaining. Also, it helps if we have growth charts. So if you come with a growth chart from your pediatrician, it is super helpful for me because then I can see, how much you've been growing over, let's say, the last year or two, instead of just looking at one single height measurement in time. So it's really helpful if you bring your child's growth charts from your pediatrician to that first visit for the question of scoliosis.
Yeah, that's a good explanation of skeletal maturity. I know a lot of our patients always get weirded out when we talk about their periods and when they've started and why they're having them.
Yeah, they're like, why are you asking? That sounds really creepy. Yes. I don't want to talk to you about it.
Right. It's good to know there's a good explanation behind that.
Yes. And some of the dads are like, I don't want to talk about this. But yeah, so it's just one of the pieces of information that we use to help us decide, do you have a lot of growth remaining? And then really the key question is, how much do we worry that this curve is going to progress rapidly? Because that's what we're really trying to avoid.
Mm-hmm, mm-hmm. Now, when you talk about 50 degrees, for the scoliosis curve, like that kind of being the threshold to talk about surgery or, kind of entertain the surgical option, is that 50 degrees standard? Is that kind of like the standard for everybody?
It's pretty standard. I would say, some people will cheat that down into the 40s, like mid 40s. But honestly, what we know from like long-term research is that patients that have a 50-degree curve or less, when they reach skeletal maturity, the likelihood that that curve will significantly progress, meaning like up into the 70s or 80s, is really low. And that it really is not going to impair their function, meaning it's not going to impair what they do for a job, what they like to do for recreation. And I think the only thing that the research shows is that on average, you probably just have a little more back pain than someone who doesn't have a 50-degree curve, but it doesn't cause you to lose days from work. You're not taking significant pain medication. Often it just requires some over-the-counter medication and honestly doing, some stretching and some physical therapy, exercise often helps a lot.
Mm-hmm.
So that's sort of why we've set that 50-degree threshold for a surgical indication, because below that, we can't really prove that we are going to benefit you as a patient by fusing your spine. And we always want, like for me, whenever I operate on a patient, I want to have them have a functional benefit, meaning I'm going to make them better than they were before an operation.
Mm-hmm. Mm-hmm.
And so that's why we use that criteria.
Gotcha. Out of the patients that you meet, you know, the kiddos that are at 50 degrees with their scoliosis, what kind of percentage would you say decide to proceed with surgery? And what kind of percentage would you say decide not to proceed with surgery?
Yeah, it's really funny. So if they have a 50-degree curve or greater, but they're mature, meaning they're done growing, I really feel it depends on what they do for their, what I call extracurricular activities, right?
Mm-hmm.
So if you're a football player, a gymnast, a diver, you know what I mean? A lot of them will choose to monitor the curve and just watch it like through the high school years, because number one, they don't have any time in their schedule to take off for a post-operative recovery. Because on average, after surgery that I do, you probably cannot really return to a sport at your previous level of function for at least 4 to 6 months after surgery, just because you have to heal and recover. And so a lot of kids are so busy, they don't even have time to kind of fit that recovery period into their schedule. So then they kind of do all of that activity. And then if they're not going to like get a college scholarship, or they're not, you know, it's not going to be a predominant portion of their life, then they often choose to have surgery to correct their curve, sometimes after their freshman or sophomore year in college, or when they're on a winter break from college, or sometimes the summer before they go to college. Whereas other people, let's say they're not super active, they don't have a lot of extracurricular activities going, they like love to draw and they're in theater, then sometimes they say, I don't like how my shoulders higher and my ribs stick out, and I would like that fixed. And then we kind of say, sure, we can do that whenever it fits into, let's say, whatever you have going on in school. But on average, most kids, if they have this surgery during the school year, we put them on homebound for a month, meaning we fill out the paperwork and the teacher will then come to you and help you with your homework for, 1 month following the surgical procedure. Most kids feel well enough to be like off narcotics and doing some local activities around the house. But I think it is unrealistic for us to think that they can sit in a classroom chair for 8 hours a day after a big spine surgery without, needing breaks or going to the nurse's office or getting some pain medicine. So that's why we set the homebound period for 1 month after surgery. Mm-hmm. And you take care of these patients a lot. Do you feel that's also true? They feel well enough to like go out and about in the community, but to sit for an entire school day in the hard chairs at school after spine surgery, I think can be difficult for the first month. Yes.
Yeah, I agree that, the endurance, it takes a while for them to kind of build their endurance back up.
Yeah, they get tired. It takes your body a while to get its energy back. And so sitting through an entire day of school is exhausting, after a big surgery like this. And so that's another thing that plays in, sometimes they're like, my junior year is like the most important year. I can't take any time off school. So then they say, I'm going to do it in the summer. So that's the interesting thing, is that our patients, we tend to do the most amount of spine surgery in the summertime.
We'll be right back after this.
To receive the latest news from Scottish Rite for Children, patient stories, videos, blogs, and more, follow us on social media. Through Facebook, Twitter, and Instagram, we share inspirational stories and educational resources for you and your family.
We're back to Checking In with Scottish Rite and your host, Jennifer Bowden.
So tell us what the biggest benefits of surgery would be, Dr. McIntosh. Tell us what, really benefit the kiddo after surgery.
Yeah, so I think the biggest benefits of surgery are, number one, I correct your curve. So, you go from a 50-degree curve or a 60-degree curve down to something it's never perfectly straight. So it's never zero, but it's down into the teens, which is, when you look at an x-ray, it's amazing. So you get curve correction. Number two, you immediately get taller because of your curve correction. So it's the fastest way to grow in a day. So most patients get between an inch or two taller just from correcting their spine surgery. And then three, that risk of progression we were talking about, that completely goes away because you no longer can progress because now the instrumentation will hold your spine in that corrected position forever. So then you have no risk of curve progression.
So it doesn't get any worse.
Correct. Mm-hmm. So you get correction and that risk of progression then completely goes away. And then, I'm not going to lie, there's a cosmetic benefit, right?
Yes.
So what they see a lot of times is, this asymmetry, like their shoulders high, their ribs are asymmetric. Oftentimes there's some chest wall asymmetry or some breast asymmetry. And then if you have a lower lumbar curve, there's also some waistline asymmetry where it looks like people always tell me my hips aren't level, where in reality, your hips are level, your pelvis is level, but it's your lumbar spine that's asymmetric. And so there's that's called waist asymmetry. So after surgery, all of that is dramatically improved as well. So there is what I would call a cosmetic benefit to the surgery as well. Mm-hmm. But it is not a cosmetic surgery. People ask me that all the time. No, this is a medical necessary procedure. The reason we're doing it is to prevent progressive spine deformity, which can later impact you in later life. And there is a secondary cosmetic benefit, but that is not the goal of surgery.
Right. I know. I think some of my favorite parts about these AIS kiddos that have surgery is, we take their photos before surgery.
Yes.
And we take their photos after surgery.
I know.
Kids
and
will
then
come
you
back.
Show them.
Yes.
Yeah, you show them, and they cannot believe. Like you take their pre-op pictures and you match it to their X-ray, and then after a year, we often get another post-op photograph with their X-rays, and we show them the X-rays, and then we show them the clinical photos. And they honestly are like, I can't believe I that's what I looked like.
Right.
And you're like, I know it is. And that's another beauty of our hospital. I think that most people don't understand is that our media department is amazing. And we take clinical photos of every spine surgery patient before and after surgery. So, just having that photo catalog is amazing.
Yeah.
And it really helps. Don't you feel like it helps also, when I'm trying to talk to a patient about scoliosis and surgery, where we have some of these photos that are obviously, changed so that we don't have any patient information shared, but we can kind of give people a clinical or visual picture of what correction looks like when we're educating them pre-op. And I think that is very, very helpful, especially for these middle school and teenage girls where, honestly, body image is very important to them.
Mm-hmm. And, the incision and the scar concern, that a lot of that is alleviated with our media photos. Everybody can kind of see, what a fresh incision looks like, meaning immediately after surgery. And then one, a year out that's healed up and is really fading and getting very thin.
The other thing I love about Scottish Rite is our peer support program.
Yes.
I love it that we have these group of patients that have gone through surgery and now they are acting as a peer support for patients that are going to have surgery. Because I always say, well, I do this surgery, but I don't know what it feels like to recover from this surgery. But we have this whole kind of list of patients that are willing to be a mentor or a peer and to kind of help them, prepare and get through the process, which I think is also like an amazing program at Scottish Rite.
Yes, I agree. We use that frequently, for sure.
And I think it is really helpful for the patients, both before surgery and the ones who have gone through it, because they kind of feel like they're giving back, which I think, makes them feel like the whole process is really complete for them.
Right. I agree. So in talking about the benefits, of course, there's always risks with surgery. Can you kind of guide us through some of the biggest risks of the surgery?
I think this is important to talk about because for some reason, I feel like, especially now, everybody feels like, this is like not a very like big surgery, but it is. I mean, it's pretty big surgery, right? You're getting screws and rods put into your spine. And there's important things around the spine. There's the spinal cord, there's like major blood vessels, there's your lungs. And so, I mean, I think we do this surgery so well and so safely, and we've made it so efficient that I think we all kind of forget this is really big surgery. So whenever I'm talking to a patient and their family, I don't want to scare them, but I do want them to understand that there are risks involved in everything we do, and that we at Scottish Rite do everything we can to minimize the risks, but they're still not zero. So I think the biggest risk after a surgery like this is an infection. And honestly, at Scottish Rite, our infection rate is about 0.4% for this surgery. But I quote, because the literature quotes, about a 1% infection rate. So 1 out of 100 patients that has surgery for adolescent idiopathic scoliosis will get an infection. And it's not like a little tiny, pimple infection. It's a deep spine infection, which means that the metal implants have bacteria on them. So you have to go back to the operating room. You have to open up the entire incision. It has to be irrigated or washed out and cleaned really well. And then you have to go on antibiotics for often a prolonged period of time, sometimes even 6 months after a deep spine infection. So that is obviously a big deal. And we work really, really hard at the hospital to make the infection rate as close to zero as possible. So that's the biggest risk. I think after that, it's probably a risk of a blood transfusion. So for AIS, we're getting it down to maybe just like 10% of patients get a blood transfusion. We use what we call cell saver, which means we can have a special sucker in the OR that takes the blood out of the surgical wound, and it goes through a special machine so then that your blood gets recycled and given back to you. So you're not having to get blood from the blood bank, but you're donating your own blood back to yourself. And we call that cell saver. I think then the third risk is probably a risk of some hardware malfunction, meaning either one of your screws or the rod, something like disengages or breaks, and then you need to have a revision because your hardware failed. That is, again, a very, very low percentage, but it's not zero. But I think the risk that everybody worries about the most is neurologic injury, meaning while we're putting the screws in or doing the correction maneuvers, your spinal cord gets unhappy, and then you wake up with some numbness or weakness in your lower extremities. That risk is in the literature reported at about like 1 in 10,000. So really low, but when it happens to you, doesn't feel like really low. And we run what we call neuromonitoring on every single case. So that means while you're asleep on the table, we put little tiny electrodes into your scalp and along your skin, and we run just a little bit of electricity through your body. And then I can see on a monitor during surgery your spinal cord, because your spinal cord is like a wire. It's kind of like a fancy wire in your body. And I can see the waveforms when the electricity is kind of running through your spinal cord and your nerves and how your brain perceives that. So every case has spinal cord monitoring. at Scottish Rite. And the nicest thing about that, just like our orthotists are in-house, our spinal cord monitoring team is in-house. And so we work together with these people every day, and they are really, really amazing at their job. So I'm going to knock on wood. I've never had a permanent neurologic deficit, right?
Yes.
Like, so that's the thing. So I've never had a patient, wake up with, numbness or weakness that, doesn't completely resolve and they get back to their complete normal baseline function.
Right.
But there are cases in the literature where that happens. But again, we do at Scottish Rite everything in our power for that to be like a zero event or a never event.
Right. And just, for all of our listeners, all of those things that Dr. McIntosh talked about, the cell saver, the neuromonitoring, the electricity types of things, that all happens while everybody is asleep.
Yeah, you're asleep.
Yes,
you are totally, I know everybody, when I talk, I literally have the same conversation with my patients and their parents in a room. And you've been there, you've been with me, Jennifer. So you see their eyes and then they're like, oh my God. And I'm like, no, you're totally asleep.
Everybody's asleep.
You don't know that any of this is going on. You don't feel anything. It's just, this is all of the precautions that I, as a surgeon, take and like the entire team here at Scottish Rite takes to make sure that you have a successful surgery with no complications.
Right.
It's kind of like it's just constantly happening all the time.
Yes. Yeah.
And that, we could probably talk about infection then. So, cause you and I worked really hard on this we've worked so hard on it. So now it seems a little crazy, but before surgery, for 2 days before surgery and the night before and the morning of, we're making you bathe your skin with sort of these special wipes. And the goal there is to decolonize your skin, meaning all of us walking around all have bacteria living on our skin. It's just called normal flora. Well, before a big surgery like this, we want that normal flora or normal bacteria in our skin to be at its lowest amount possible. So we have this sort of pre-operative bathing regimen that we have all the patients go through to kind of decolonize or decrease that number of bacteria in our skin to the lowest amount possible before surgery. And then, of course, everybody gets antibiotics before and during surgery and for 24 hours after surgery. We are trying to take out Foley catheters, which are catheters that go in your bladder so that you don't have to get up and pee all the time. We're trying to get those out as soon as possible, like the first night of surgery, if possible, to avoid any urinary tract infections. We also are getting the lines or the IVs or the ART lines out as fast as possible to avoid any infections associated with those lines. And then frankly, we're getting you up and mobilizing you. I mean, you get up and you sit at the side of the bed or sit in a chair the same day of surgery, and you're walking to the bathroom if you want to on the same day of surgery. And then you're walking the floor, laps around the floor on post-op day 1. And all of that is to try to prevent any pneumonia, try to prevent any ileus or constipation, because if you lay in bed, all of those things are a lot more common. So everybody is like, when am I going to be able to move? And I'm like, you can move on the day of surgery. Like, your spine with all the instrumentation is super stable. There's no reason for you to be bed bound. So I would say we're fairly aggressive at Scottish Rite in getting people mobilized quickly.
Mm-hmm.
And honestly, because, you helped me build the program. I mean, we do a great job at avoiding infections and complications at Scottish Rite.
Right. I know you and I both are part of our surgical site infection committee here at Scottish Rite that kind of oversees all of that, builds, our bundles for, making our checklist to really help kind of prevent infection and kind of head off any type of environment or situation that would lead to an infection. So I think that's pretty unique.
Yeah. And I just found out, this is exciting. There's a big kind of hospital group or overseeing hospital group called Solutions for Patient Safety, or SPS.
Mm-hmm.
And we're going to be awarded part of their Shine report because we have done such an excellent job with our surgical site infection bundles and compliance with those bundles and working to lower our infection rate to 0. So that's really exciting news. I know.
That is. That's excellent.
So a little bit of praise from solutions for patient safety, which is
that's
excellent.
Very cool. Very cool. Can you, Dr. McIntosh, talk a little bit more about antibiotics? Like, how do we use antibiotics in the, before surgery, in the operating room, after surgery? Kind of talk about that. I know that's a big question among parents is,
it is.
Do we have to take antibiotics?
Yes, you do have to take antibiotics. So, so it's mandatory. It's part of one of our infection bundles. So every patient within an hour of the surgical incision being made gets IV antibiotics. So they get a dose of antibiotics in their IV and it's circulating in their bloodstream at the time we're making the incision. Then depending on how long the surgery takes, if the surgery is more than 3 hours, you get another dose of IV antibiotics while you're asleep in the operating room. And then we continue the IV antibiotics for a total of just 24 hours within the surgical episode of care. And then after that, you won't get any more IV antibiotics. Now, some patients, depending on their risks and other things, so like if you have a higher BMI, or you and I know one of our frustrations is kids that have acne on their back or back knee, that actually predisposes you to infection as well. So we will often then put powdered forms of antibiotic into the surgical wound, just as a local antibiotic to try to prevent any infection as well. So there's IV antibiotics. So that's systemic. It goes in your body. It circulates in your bloodstream. And then there's local antibiotic, which just means it's like a powdered form of an antibiotic that we put into the surgical incision or site as we're closing it.
Gotcha.
So those are the two forms of antibiotic that we use to try to prevent infection during scoliosis surgery.
Good. That's good. All the bases are covered with antibiotics.
Yeah. Because like I said, getting a deep infection is a really big deal.
Right. Tell me, like, in the operating room, who all is in the operating room with you? Like who else kind of watching over the kiddo?
It's actually a really big team, right? So I always say I'm the captain of the ship. So like I'm in charge of the whole team, but I have me. So I'm a pediatric orthopedic surgeon. Then we also are what we call a training facility. So we train 5 fellows and up to 9 residents a year. And so there's often a resident or fellow who's working with me. And then we have what's called a surgical assistant. And that is a person who has a college degree in being a scrub tech or an assistant in the operating room. So that person is there standing next to me, handing me all my instruments, giving me the screws that I'm putting in. Then there's a circulating nurse. So this is a nurse that works in the operating room. And the entire time she's making sure that I have everything I need because I'm scrubbed and sterile. I can't touch anything. So she's the person who's not scrubbed in, but she's getting me anything I need during the case. And then there's the anesthesiologist who's keeping you asleep and making sure you don't have any pain. And then there's the neuromonitoring technician. So that's the person who is running the neuromonitoring for me so that I can see how well your spinal cord likes surgery. And then because we're putting screws in your spine, I always have a radiology tech in the room. So that's a person who has a degree in how to run radiologic equipment. And they are running a special type of X-ray machine and a special type of CT machine that I can use in the operating room. So I know exactly where I'm putting the screws. So it's a really big group of people, isn't it?
Yes, it's a great team in the OR. That,
yes.
Everybody's got their eye on something, which I think is really important for our parents, to understand.
Yeah. So it's funny that it takes that many other people for me to be, super successful and efficient at doing spine surgery as quickly and as safely as possible.
Right. What I think here at Scottish Rite, we do a really good job of keeping our parents and informed.
Mm-hmm. Yeah, that's another thing that the circulating nurse does that I forgot to say. So not only is the circulating nurse making sure that I have everything I need, the circulating nurse is constantly kind of keeping track of where I am in the case and giving the parents updates. So then calling the parents and saying, we just made incision, or saying, okay, now the implants are going in. Okay, we just did the correction. Okay, now we're closing. You know what I mean? So then there's constant communication with the parents during surgery also as to like how the case is progressing. And then as soon as I'm done and the patient is off the table and in the recovery room, then I go out and before coronavirus, I used to talk to the patients in person. Now I talk to them on the phone, and then I show them what the corrected x-rays look like.
Right. So I think that moment is so fun because some of our surgeries here at Scottish Rite, there's not really an immediate change or an immediate benefit.
That's why I love what I do. It's so rewarding visually, right?
Right. Yes. This one, you can definitely see a change immediately. And so I think the instant gratification on this type of surgery is fun for everybody.
Yes. The parents, it's crazy, but they are often like crying tears of joy. I think it's partly relief that, their child had this big surgery and they've gotten through it safely. But second, when they see that visual change in the x-rays, they're literally like blown away most of the time.
Right. Yeah. That's a fun moment for them.
I know it. Like people always ask me, I mean, there's so many great things about my job, but that is definitely one of the perks of my job is just getting to see parents' reactions to how nice the correction turned out.
Yes, I agree. I know we talked a little bit about kind of getting up and moving around after surgery, being able to walk and move your arms. Kind of tell us why it's so important and why we get everybody moving so quickly.
Yeah. So we know that just sort of laying in bed is just not good for you. It's not good for your lungs. It's not good for your digestive system. And it honestly, you think it's going to make you feel better, but it makes you more sore because then your muscles aren't moving and they're just getting more tight and more sore. So part of our post-operative program is sort of a very aggressive mobilization where the nurses are constantly having you moving your shoulder muscles so that they're kind of not feeling tight. They're almost getting blood supply and warming up. You're sitting up in a chair to eat because that helps with your digestion and it helps with your lungs to like breathe more normally. And then you're just walking, laps around the floor. And all of that is really important to actually, it's weird, but you almost feel better as you move more. Mm-hmm. And we know it prevents complications. We know it prevents having any issues with those other organ systems. So on average, like I said, people are sitting at the edge of the bed or sitting up in a chair on the first night of surgery. And then, walking to the bathroom and walking laps in the hallways on post-op day 1. Mm-hmm. And most patients now stay in the hospital 2 days. And sometimes 3 days, just depending on what type of a drive they have home, how far away they live, kind of, I'll just say social semantics. But yeah, most people are ready to go home on post-op day 2. And they're sitting in a chair and walking on the day of surgery.
Yeah. I think it's important to know, our nurses do a great job of, instructing the kiddos how to get up, how to turn over, how to.
They're amazing.
Right. I think.
And I always tell people, you're going to be comfortable. You're not going to be afraid to go home or to help your child. Like we're going to take care of all of that for you so that when you leave, you feel ready and comfortable to be at home.
Right. I think a lot of our patients think that we just expect them to know how to do all those things after surgery. But I always reassure everybody, that we all help you, we all teach you, and we all support you in getting moving.
We know this is new to you. So we teach you everything, mm-hmm. and our nurses do an amazing job.
Mm-hmm. And again, I think it's important to know that we really expect and educate, the families to keep moving at home. So once you go home, you can't stop moving.
Right. So that's the other thing I tell people is every single day, I want you to have some planned activity, like whether it's you're going to walk to the mailbox and get the mail, you're going to walk up and down your driveway a certain number of times. But there has to be scheduled activity at home as well. Because oftentimes if there's not, they felt good in the hospital, but then they go home and they sort of start lying around and they actually feel a little worse.
What type of, I know we get this question a lot. What type of accommodations do parents need to make at home for their kiddos once they've had the surgery?
Yeah, that's a really good question. I think at least for the first few nights at home, it's not a bad idea if their bedroom is upstairs and doesn't have a bathroom close to it and isn't like close to where you are. Probably better to be on the same level as the parents' bedroom and to be in close proximity to a restroom, just because they sometimes still do need a little help getting up and out of chairs or up and out of bed. And then making sure when they get into the bathroom, they may or may not need any help getting up and down off the toilet. And so making sure that there's like an environment that creates safety, meaning the likelihood that you're going to fall or, trip is basically eliminated is the best case scenario. And it's not forever. That's just, sort of in that transition period. And then as everybody's feeling more comfortable and better, sometimes within a few days or a week, then they can transition, back upstairs, back to their own bedroom. But I think in the beginning, it's better to be on the same level as the parents and as close as possible, wherever they're going to be staying, at least as close as possible to a restroom. Would you agree?
Yes, I agree. Talk a little bit about showers at home.
Yeah, so I think it's important to shower. I think that middle school kids and teenagers get a little stinky if they don't shower. And so I actually encourage showering at least every couple days. And when you go home, we send you home with a dressing on your spine that the company says can last 7 days and you can wear in the shower. So we send you home with extra of the dressings. And then I just tell you to use your best judgment. So if the dressing got really soaked or feels really wet, we don't want that sitting on your incision. So then you can always just take the dressing off after the shower, make sure the area is clean and dry, and then place a new clean dressing. But I think showering is good. And I think not every day. Would you agree?
Yes.
Every 2 or 3 days. Is it not a bad idea? And it's important to sit in the shower. I think if you stand up, you have a little more potential to have what we call a vasovagal event where you kind of get lightheaded and dizzy and you pass out. And so I always say, if you don't have a shower chair, then getting like a plastic chair from like Target or Walmart that fits in your shower so you can sit down for the first few times showering. And then also I think it's a better idea to have the water of the shower kind of hit your front and not be like pounding on your back, at least for the first couple of weeks, just so you avoid any significant irritation of the incision.
And I do think it's important, I think especially a lot of our teenagers, it's kind of weird, but it's a good idea to have somebody next to you for the first 2 or 3 showers.
Yeah, like it's gross. I know, like, no one wants their mom standing next to them while they're taking a shower, but you can still have your privacy, but having the parent be either in the bathroom or right outside the door while they're taking their first few showers. Don't you agree?
Agree.
Yeah.
Agree.
You're listening to Checking In, a Scottish Rite for Children podcast.
Do you have a story to tell? We want to hear it. Sharing your experience with us can provide inspiration to other patients and shine light on our mission of giving children back their childhood. Whether you are a current or former patient or family member, we invite you to share your journey with us. To submit your information, visit scottishriteforchildren.org/share-your-story.
Welcome back to Checking In, a Scottish Rite for Children podcast.
What about, can you talk a little bit about pain medication, Dr. McIntosh, after surgery and going home with pain medication?
Yeah. So everybody who goes home with prescription pain medication. They often require narcotic pain medicine, either in the form of oxycodone or hydrocodone for the first week or 2. And they take that on a schedule. Usually you're taking that every 4 to 6 hours, in addition to Tylenol and Motrin. So the Tylenol and Motrin is key. So you take that scheduled, and then you take the narcotic pain medicine, on top of that. And then I personally like to send my patients home with some Valium. I think that there is a lot of muscle soreness and muscles kind of spasm after this surgery. And I do think the Valium helps a lot, especially at night, to help get through the night, the first, few days to a week. So I often send my patients home with a prescription for a narcotic pain medicine and for Valium, which is a muscle relaxant.
And again, I think all of our staff, our docs, residents, fellows, nurses, we all do a great job kind of instructing about pain medication, timing.
Yes, the schedule and the timing and the dose.
So you'll be prepared.
And most patients don't require the narcotic pain medicine or the Valium more than the first, I would say 10 to 14 days. And then after that, they're just taking Tylenol and Motrin during the day. And sometimes they need either their narcotic or Valium at night, to get through the night for a little bit. But they get off it really quick. And everybody always says like, oh, am I going to get addicted? No, most kids want to get off it as soon as they can because they don't feel good on it. And honestly, it is constipating and they really hate it, that it makes it hard to poop. So I feel like all of our patients, get off it pretty quick.
Good to know. So once they've gone home, recovered, kind of talk about how often we see them back, how often we check x-rays.
Yeah. So this has actually changed a little bit with coronavirus. I'm trying to do all the 2-week visits virtually now because it's really about how is your incision? Do you need more dressings? Do you need any more prescription pain medication? How are you doing eating and drinking? Are you getting up and walking every day? And before, I used to schedule that in the clinic to come see me, but with coronavirus, I don't know that that's necessary. And so I've been doing virtual visits where we are on video together and I can take care of all of this for them remotely. But then I do like to see them at like the 6 or 8 week time frame because 1, I like to get x-rays as a new baseline. And 2, that's when they're feeling well enough that they want to start doing some activities again. So that's when we start talking about what activities are okay, and oftentimes going back to school, gym, things like that. So then I see you at 6 or 8 weeks and then 6 months, 1 year after surgery, 2 years after surgery, and 5 years after surgery.
So we keep a pretty good handle on our post-op kiddos.
Oh yeah. But the virtual visits have been going really well. For
I
patients.
think that's a good option for a lot of our kiddos, especially at the 2-week mark.
Especially if you're at any distance, you know what I mean? It's a lot more convenient.
Right.
I think.
Right. What about as our kiddos become adults and, they have the spinal hardware and, they had scoliosis. Do they need an adult specialist, for the rest of their lives?
I think if you have instrumentation in your spine, it is not a terrible idea to maybe check in with an adult spine surgeon every 5 to 7 years, just to make sure everything's looking and going okay. If you're not having any symptoms or problems, you could maybe even go every 10 years. You know what I mean? But I think it's unrealistic to think that if you had hardware put into your spine when you were like 13 or 14, that you're never going to need to see an adult spine surgeon. Like that's an unrealistic expectation.
Yes. Okay. And I think Scottish Rite also does a good job of, helping our patients identify,
oh yeah,
good
we have
adult
a
docs.
list of really good adult docs in the community that we know and we work with and we've operated with and that we trust, and we give that to you when you become an adult.
Right. Well, good. I think a couple of important questions that I know that I've encountered, and I'm sure you have too, is after surgery, will our patients be able to have a baby? I think that is a big question that our parents have
all the time. And I don't know if it's because I'm a girl surgeon and they're just more comfortable, but I get it asked like probably 5 times a day. The answer is yes. You will be able to have a baby. You will, honestly, there's no reason you can't have the baby vaginally. And most of the time, there's no reason that you can't have an epidural. But there was just a study that is probably going to get published, but I saw it get presented at the podium, where if you have any spinal instrumentation, the obstetrician gynecologists are more likely to schedule you for a C-section, not because you couldn't have the baby vaginally or have an epidural. I just think it makes them uncomfortable.
Mm-hmm.
So you can totally have a baby, you're going to carry a baby to term, but just because you have spinal hardware in, regardless of how distal a level, meaning if your hardware stops in the thoracic or lumbar spine, you're more likely to get a C-section, just because I think it makes the OB-GYNs uncomfortable.
Interesting. Yeah. So
isn't that interesting?
That is. So I think, it's important to know that, our patients, as they grow up, they always need to tell their other doctors. I've had a spine surgery.
And the doctor's obviously going to look at their back and see a scar and then be like, you know what I mean?
Mm-hmm.
But I think if they really wanted to have a baby vaginally and have an epidural, they can totally talk to their OB-GYN about it. And I've actually written letters on behalf of my patients saying, I see no reason why they couldn't have a vaginal delivery or why they couldn't have an epidural. You know what I mean?
Mm-hmm. Mm-hmm.
I think we need to communicate better with the OB-GYNs about that.
Right. Yeah. And I think we've gotten better about that, but yeah, there's always more communication that can take place, and I think it's important to know that, our parents are, and I get calls all the time. Our parents can always call us no matter how old the kiddo is and we can help.
No matter how old, like forever, you could call us.
Yes.
And we would help you.
For sure.
For sure.
What about we get this question a lot. Did the screws and rods need to come out at some point?
They don't.
After they've had surgery?
They are created to hopefully last you a lifetime. So our goal is for you never to, I always call it one and done surgery. Our goal for you is to have one surgery and never need another surgery. And so they do not have to come out.
Good deal. What about, this is a good one. Will they set off metal detectors in the airport?
Oh, I love this question. There was a study on this as well, but it was the old metal detectors, the ones you walk through, not the new ones where they stand and scan you. So in the old metal detectors that you walk through, there was a 25% chance you would set off the metal detector. And that was much higher if you had stainless steel implants. And all of the implants we use today are titanium and cobalt chrome. So I think it's not zero, but I think it's pretty low. And in the new scanners that they scan you, I think they can see it. And so they are probably going to wand you and then want to see your scar.
Mm-hmm. And then we don't give out the cards anymore that say you have an implant in.
No. The Homeland Security does not care if you have metal in your back. So they are going to wand you and look at your scar, and you could present them any amount of information that you have metal in you, and they still are not going to care.
What about driving after surgery? Because a lot of these kids are teenagers.
Yeah. So I think that you can drive safely as well as you could drive before surgery. So if you're a bad driver before surgery, it's not going to make you a better driver after surgery. And you have to be off narcotics. So you cannot be taking narcotics. And you have to feel like you can control your vehicle in an emergency situation. So you have to be able to feel well enough that you can look over both shoulders, check behind you, check your mirrors, and, be able to control your car in an emergency situation. So if you don't have a positive on all of that, then you probably shouldn't be driving. And I would say most of our patients are able to drive usually after the first 3 to 4 weeks.
Good deal. I think
as long as their parents say it's okay.
Right.
Yeah.
Right. And then I think lastly, talk about kind of movement after you're healed from surgery. The bending looks a little different. The twisting looks a little different.
Yeah, it totally depends on how low we had to fuse your spine. So if I can stop your fusion in your thoracic spine, which is the part of your spine that's attached to your rib cage, you are going to have full motion. Now, if I have to fuse you down into your lumbar spine, so lumbar 1, 2, 3, 4, or 5, the lower you go down, the more I think you feel stiff. And honestly, the most stiffness happens if we have to go down to L4 or L5. And we try to honestly avoid that if at all possible. So I am always surprised. I saw a patient back on Tuesday who was young, had a really big curve. I had to fuse them down to L3. He can touch the floor.
Wow. Yeah.
Yeah. I mean, And I asked him, I'm like, do you feel like you've lost any motion? And he can't tell.
Mm-hmm.
So really it's the fusions that go down. I think when you think about it, people think about like adult degen surgery. So like anytime you have to fuse L4, L5 or S1, you're definitely going to lose motion, but we try to avoid that at all cost. So I would say the majority of our patients maintain the majority of their function and mobility after surgery.
Mm-hmm. Mm-hmm. Yeah, I think and that's a good example, Dr. McIntosh. I know these are all like, our most common questions, our most common statements, but, each kiddo is certainly an individual in their process.
Yes. And honestly, I have to ask patients, well, how well could you bend over before surgery? You know what I mean?
Yeah.
So if you can't touch the floor before surgery, that's going to be hard for you after surgery.
Right.
And that has a lot of different things. It's like, how flexible are your hamstrings? You know what I mean?
Mm-hmm. Mm-hmm.
But yeah, I would say we're very, very, very cautious about trying to maintain function and mobility after this type of surgery.
Mm-hmm. I think that's a big factor that goes into all of this.
Yes.
Well, I think we've gotten a really great overview of adolescent idiopathic scoliosis and also surgery. For adolescent idiopathic scoliosis, I think you've given us a lot of great information and answered a lot of good questions. Is there anything that you think you'd like to add or?
Yeah, I just wanted people to know. I mean, like I said, surgery is it's a big deal. But like I've said, we have, worked really hard at making it, the most efficient, safest, most standardized operation we do at Scottish Rite. So honestly, we do over 300 of these surgeries a year. And it shocks me how well everybody does.
Mm-hmm.
You know what I mean? Like it blows my mind. Like I just saw a patient back last week. And she wore a brace for a little while and it didn't work out and her curve progressed. So she had surgery. And this is crazy, but she was like, surgery was easier than wearing the brace.
Yeah.
And I was like, that's crazy. But then again, like, I don't know what it was like to go, to school wearing that brace every day. You know what I mean?
Mm-hmm. Mm-hmm.
And I go, yeah, I think it just comes down to, every patient is different. And so for her, wearing the brace was really hard. Like it was just really difficult. I think because she was a swimmer and she was really athletic and functional. And for her, she said like recovering for surgery wasn't hard. And she was like, I wish we would have just done it sooner.
Mm-hmm.
I was like, okay, you know what I mean? But that's a really interesting perspective that I guess I never even thought about, that for some people, surgery is easier than wearing the brace.
It is surprising how well these kiddos do after surgery. I always think back to our ballerina, Dr. McIntosh, that we took care of.
Yeah. Oh my gosh. Yeah. So Jennifer's talking about this patient I took care of that literally like got a scholarship to Juilliard. Like she was an amazing ballerina, but she was a lot of skeletal immaturity. She had a lot of growth left and she already had a 50-degree curve. So she got spine surgery and literally on post-op day 1, I rounded on her at late afternoon and I was like, how'd your day go? And she was like, oh, I'm a little sore. And I was like, oh yeah, usually everybody gets a little sore because they're walking. And then her mom shows me a video of her balancing on one leg and then raising her other leg, like completely above her head and holding like one leg above her head while just balancing on her other leg, like literally one day after surgery.
Yes.
And I was like, okay, so maybe that was a little too much.
Yes.
Yeah. So that's how well people do sometimes.
She's a good example.
But that is not the expectation by any means.
Right? Nobody has to do pliés in their recovery room.
Was more than a plié. I don't even know the
that was
technical
more
ballerina term for that, but that is like when you're standing on one leg and your other leg is above your head. Like completely above your head. Yeah. It was crazy.
That was impressive.
So yeah, kids do remarkably well with this surgery. And I'm always just blown away.
Yeah.
We've really, I think, standardized this process for everybody.
Well, I mean, it's apparent that, the hospital as a whole, scoliosis is super near and dear to us. And, over the years, we've really kind of fine-tuned our approach to everything. And so, that's definitely apparent in listening to you talk about the surgery and talk about scoliosis.
Yeah. I mean, I think honestly that Scottish Rite is, one of the top scoliosis hospitals in the country, if not the world. It's amazing what we can accomplish here. It blows my mind.
I agree.
Yeah.
Well, thank you for spending time with us
nice
today.
To talk to you.
I know, it was so nice
nice
to talk to you about everything. I think we got a lot of good information. I think parents will really appreciate, kind of the bulk of this conversation, especially if their kiddo has to have surgery.
Yeah. And now they know they can call to make an appointment. You can make an appointment online. Mm-hmm. And we're happy to see you or your child if you have any, questions or concerns.
Okay. Well, thank you so much, Dr. McIntosh. We appreciate it.
Yeah. Have a great day.
Alrighty. You too.
To learn more information about any of the topics discussed on today's podcast, check out our website at scottishriteforchildren.org. And be sure to subscribe to Checking In with Scottish Rite. This podcast is a production of Scottish Rite for Children. The host for this episode is Jennifer Bowden. Our producer is Maggie Dingwell. Our editor is Amy Krajewski. Our assistant editor and recording engineer is Stuart Allman. Our theme music was composed by Scott Holmes, and his music can be found at scottholmesmusic.com. Thanks for listening, and we look forward to seeing you at our next episode.